Do you ever bring in translators when the language is not?
Yeah, it's also a very good question. I think it's really important to bring in translators, and I am very fortunate at UCLA in that we have really a United Nations of translators here, and we have translators readily available either in person or by speakerphone in dozens of languages, literally dozens of languages, Greek included, by the way. And I think it's very important not to rely on the family to do the medical interpreting, the translating during the visit, if that's at all possible. Certainly not with children of a family, of a patient, to put them in that position. But whenever possible, I like to rely on a professional translator, even if the son or daughter is completely bilingual. And I see this all the time. We have a large Persian population, or formerly Persian population in Los Angeles, and so many of the older generations speak only Farsi. And the younger generation are perfectly bilingual and speak English with really no accent whatsoever, and they speak perfect Farsi as well. And even when there's a perfectly bilingual adult child in the room, I will insist on having a Farsi translator come over, or to whatever language, come over, because it takes that responsibility off of the family member to have a professional interpreter. There are many free services that will provide this live. So even if it's not physically available wherever you practice, you can often get it either by video phone on the internet or certainly by speakerphone from volunteer services.
Thank you. Any other questions? Yes, can you come up here, please, because our mic is here.
Hello, doctor. Thank you for your very interesting lecture. Just a question. I'm not an expert. I'm not a doctor. I'm an archaeologist, so my question might sound stupid. How do you deal with children?
Maria, could you repeat the question?
How do you deal, or should we deal with children? Should we also tell them the truth and face them as adults and mature, or should we?
Right. So it's also an excellent question. Is how do we deal with children, and in what way does it differ? I think it does differ in dealing with children. The amount of information that children, they want information, but the amount that they really are able to process is, of course, much more limited. And of course, it depends on the age of the child. Whether you're dealing with a 9-year-old versus a 14-year-old is, of course, very, very different. But my general impression in dealing with pediatric cases is that we tend to underestimate the amount that the child can understand. Illness tends to mature children much faster than any of us would like to see. But one of the advantages of that is that if we invite the child to be a participant in his or her own treatment, that can be very valuable for the child. I think one of the challenges of just coming of age and growing up is learning that, you know, as a child, we don't have as much control over our lives as we would like to, and that's part of the process of maturing, is gaining more of that control, so that when a disease strikes, whether it's cancer or whether it's benign, diabetes in particular for children, to the extent that we can re-empower the child at an age-appropriate level, I think that can benefit the ultimate outcomes and certainly the relationship. I think that it's really important to talk with the family, with the child in the room, and to talk to the child with the parents in the room. So that one of the things, and my practice is mostly confined to adult medicine, but not entirely, and one of the habits that I have when I'm dealing with a child who's of enough age that they can understand, meaning above about 8 or 10, is with the child in the room, I will look and face and talk directly to the child, even though my conversation is often directed at the parents. But I will talk to the child, because there's nothing more unsettling, I think, than being a patient and being discussed in the third person while you're in the room as the patient. And we're guilty of this often on rounds, where we'll all march into a room, we'll circle around the patient's bed, talk over the patient to each other about the patient in the third person. He did this, then she did that, and then this. And it's incredibly, I think, disrespectful to the patient. And talking to the patient directly, including a pediatric patient, with an eye towards speaking to the parents, perhaps in more sophisticated terms, I think is the way to handle it. We could talk a long time about the special issues with children. Very good question. Thank you. And I must begin to wrap up if we can, Maria.
Okay, one last question. Do we have time for one last question?
Certainly.
Okay. One last question? Yes. Can you come up here, though? Here.
Thank you.
Good morning.
A little bit louder.
Yes, good morning. I would like to ask you a question about a problem that I had in my private clinic. How do you cope with delicate issues like HIV infection? Because when I had a patient of mine and I tried to explain that HIV infection was in the differential diagnosis and asked her to take a test, I think that she was shocked because this is a very delicate issue here, maybe a taboo, and she never came back. I tried to be as polite and as discreet as possible, but I think that here in Greece is a difficult issue. Thank you.
Yeah, thank you for that. I'm glad you asked that. It's also a really terrific question, and there are many delicate issues that we have to ask patients about or talk to patients about, whether it's HIV or other potentially sexually transmitted infections, whether it's issues regarding sexual function of any kind, prior sexual history, abuse, many different things that are, of course, very delicate. I think it's a delicate issue anywhere. Not only in Greece, I think it's the same amount of delicacy here as it is as it is anywhere. And I think that the way that I've handled that kind of thing in the past, particularly when it's someone whom you might not, who might not suspect himself or herself to be at risk based on behavior, based on sexual behavior, but in whom you really want to make the test anyway because it's part of your differential, I think it's important to hear what the patient's not saying. And I think that it's delicate because of issues that the patient has that she might never voice to you. She may be embarrassed about some prior sexual history or sexual contact. She might be scared. She might be a little offended at the idea of it. And I think it's important to verbalize all those things. And so I think, none of these will be successful with 100% of patients. And you may do all of these things and still have a patient that walks out the door and never comes back. But I think that you minimize the chance of that by saying something like, well, Mrs. Jones, there are a number of different conditions that might be related to these symptoms that you're having or these problems that are going on, and I want to run a series of tests. One of the tests I want to run is an HIV test, and I want to talk about that for a minute. HIV, as you know, is a virus that is transmitted often by sexual contact, but in medicine we have very strong evidence that it can be transmitted by other ways as well. And very often patients have HIV or have been exposed to HIV and they don't even know it. And they can't even think of a time in their lives where they have participated in one of the behaviors that you hear about that are most common for transmission of HIV. But I'd like to do this, and it has no implications at all about what I think your past behaviors or history might be, but I'm simply doing the diligent job that I need to do as a physician to look under every possible rock. Many of the tests that I do, that I would like to do on you, will end up being negative and won't tell us any answers. And HIV test may be one of them. But boy, I sure would hate for that to be the answer, and we missed it because I didn't want to offend you by asking. So I think some kind of conversation like that, where we actually expose and verbalize what we think the patient's concerns actually are, may help. And again, this may not be effective in 100% of the cases, and maybe you did many of these things in talking to her, but I expect that really, if she turned around and walked out and never came back, it's more about something that she's got going on in her past and not about something that you as the physician did. You can come up with a million different scenarios. Maybe she had some sexual liaison years ago and she's embarrassed about it. Maybe she thinks the husband is, carrying on with someone else and might have brought home an infection, but she really doesn't want to deal with that issue because it's just too explosive, too difficult. There's no way to know, what possible issues might be lurking just below the surface with that. And ultimately, she may just not be ready to deal with that. And so she may just, not take the test. But thank you. These are really, really excellent questions. I have thoroughly enjoyed talking with you. Please keep the slides and, look up some of the references if they interest you. And I wish you the best. And I thank you.
We would like to thank you, Dr. Litwin, for voluntarily providing your time and effort to make this evening possible. Thank you very much, and we look forward to speaking to you again in the near future.
Very good. I'll leave you with the one phrase in Greek I know. O Theos na είναι μαζί σου.
Thank you. Bye.